I know, I just noticed that they're just... Yeah. So I
will invite the people in the audience who have questions to walk over here because we're having a little bit of a mic problem. So we have just one mic working right now. Can I invite people in the audience who have questions to just come over here? Justin Perlman, Dr. Perlman.
Here's a question I'd like to pose to Jignesh Patel. You talked about the failure of a lot of heart failure agents, other than LVAD, not a whole lot of hope for big levels. One of the things that comes up sometimes that wasn't on your list is a bradycardic heart failure patient that we put on midodrine. Can you comment about its impact on blood pressure?
It's a great question. The issue of the use of midodrine, which is generally most helpful in patients who have persistently low blood pressure, does help, is really only a palliation. There are no long-term studies to suggest that the therapy in any way prolongs survival. Not known. What we do know is that the patients that we do use the drug on have a very high mortality, but of course you don't use it unless they're pretty sick in the first place. So the use of it is not associated with known increase in mortality. There's no arrhythmogenic effects, there's no other adverse effects. There is a theoretical issue of it raising systemic vascular resistance, which may not be good for cardiac function in general. And so theoretically you can make an argument that it's not beneficial. There are no clinical trials.
Early on, we used pulse-to-gimine therapy to help in stage 4 heart failure from class 2. And apart from the arrhythmias, I thought, well, how do we get the SUVs? Could be some lower keys and exits get so much.
A number of therapies have been shown to be beneficial in terms of palliation, including intermittent use of maceratide as an outpatient was fashionable at one point, intermittent inotropic therapy, but nobody has actually shown that that improves survival. Now, we do use outpatient inotropic therapy, but this is purely for palliation in patients who are truly end stage, or in patients who are candidates for transplantation and who need to wait at home on inotropic support until their heart comes along. So it's a small portion of the population, and when we do put these patients on inotropic support, they always have to have a cardiac defibrillator, whether it's an implanted device or a wearable defibrillator.
Right. Can I help you with that too?
Thank you, Doctor. I appreciate. I have one question. Doctor. Okay. I'm interested. I use plain speech to help people give antibiotics for a long time. And many years ago, one patient came to the office. He has too many problems. And I look at him, he was heavy smoker, he was heavy drinker, he was heavy. I checked his sugar was 250, cholesterol 250, and he loved to sit, watch TV, and he did not have any social activity, and he just liked to enjoy life by himself. And he asked me how to take care of his body. And I asked you, if you have this patient, they have all the bad habits, you name it, all the bad habits, what would you do? If you have only one choice to make him change, I have been listening, I watch you all your recommendations. Lose weight, healthy diet, exercise, Who can achieve all those? You patient me many years ago. It's hard to convince him to make a life change. If he can make only one change, which one would you recommend? Only one big change. Which one would you recommend?
You ask very difficult questions. I think, firstly, why stop at one change? What I would do is, does he have children? I would find his daughter, and I would talk to his daughter, and I would make him work on the father. And I would go through each list and try everything you can. Why stop at one? But if he doesn't take care of himself, then we can't take care of him.
Right. If he can make only one change, it's hard to change everything. It's not possible. This is my philosophy. I have read a lot. People in this country, not just in any country, human beings they know everything. They know what is right. They know what is wrong. They know what to do. They know how to do, but they just don't do. Now what would you do? If all those bad habits, you name it, if he can make one life change, only one, you think family will take care of his other problem?
Smoking.
No, I don't think so. Listen now, okay, exercise makes everything better. Harvard Medical School says, exercise makes almost everything better. You name it. Help people quit smoking, help you lose weight, control sugar, diabetes, make more friends. You name it, all the bad habits will get better with exercise. That's Harvard Medical School says.
I think that's a wonderful idea. There's a question behind you.
I think this is for behavioral medicine. I know there's advice how your applications with the monitoring for monitoring to inform a life towards one of the ones that you have the doctors and recommend.
The question about using sort of smartphone applications or mobile apps monitoring data. So the answer is they're expanding, they're sort of booming. There's a bunch of different companies. I think I have many patients that use them. Probably AliveCore is one of the most popular. They are very useful. I think because they're useful from the point of view of symptoms for monitoring. So there's two types of, when we talk about monitoring for AF, we're really looking for sort of routine monitoring where we're trying to pick up asymptomatic episodes in those patients, especially that we've done procedures on, because we want to make some decisions regarding anticoagulation. But then the other issue is symptom state, because a lot of patients develop symptoms that may not be related to AF, they may be related to random PACs or other arrhythmias. So I find them very useful, and actually what can happen is they record short periods of data, and then the patient can actually save those as PDFs, and they can be emailed, they can be texted, they can, so it will definitely revolutionize, I think, how we monitor patients. Oh, absolutely.
Perhaps I can sort of stimulate a related question. So from Mike Shahada's lecture, what I took away was there's all kinds of atrial fibrillation. But at the two ends of the spectrum, the decision is easy to make. So you have, so Dr. Wang, this question is directed at you. So at the two ends of the spectrum, the decision is easy to make. For paroxysmal atrial fibrillation, ablation is many times a cure, maybe for 80 to 90%, right? At the other end, if you have somebody with a very big atria, that even if you cardiovert them, they are not going to recover from atrial fibrillation. You're not going to do anything with them. Let me ask you about the people in the middle. The people who are the persistent atrial fibrillation, who are a headache for me personally, okay? They come in, maybe they have hypertension, maybe they have diabetes, maybe they're obese, and they have atrial fibrillation, but the atrium is not too bad, the atria are not terrible. Well, you ablate them. Would you ablate them once? Sometimes they need to come back for spot welding. Would you ablate them twice? Would you ablate them 3 times? Or would you ablate them forever? Or God forbid, would you send them to a surgeon? What is your practice? So, Dr. Wang is the director of the EP lab at Cedars-Sinai.
It's very important for the atrial fibrillation. We usually, for sure, everybody knows younger patients how we do it. But for the persistent patient, we don't do very old. Whenever some patient have a 75, they're very healthy, very active. And before I do ablation once, maybe twice. And we have a good surgeon, I send the surgeon, and he cure the patient. Now I start the individual by the patient. The patient very big atrium, very persistent, long persistent atrial fib. I usually see the patient with surgeon together. I offer, you could be high rate cured, 90% get a cure. Usually they get atrial flutter. We're a good center. The atrial flutter after the surgical and the AFib ablation is very difficult. We have a publication where we almost at least 90% success on that. So I want to be a good guy before I'm a bad guy. I did this few times, I give him and the patient he cured now. And I can do it, and then I cure the patient.
What about normal size atrium? Persistent atrial fibrillation, normal size atrium?
Usually the healthy, younger size, not too bad. I usually try. It's good. Still, we do better and better.
When do you stop?
Huh?
When do you stop? I want to push you. How many do you do?
I usually do one. If they say the patient did the one procedure, they become atrial flutter, or say, oh, I have a 60%. We all monitor the patient. The 60% of patient atrial fib, after you do, they have, maybe 5% get better and better. Maybe that situation, encourage the patient do one more time. Maybe at that time, I usually don't do third. Second time, I encourage them. It's a good chance to get a cure also. But if you have the second procedure not a success, I usually refer. Yeah. Thank you. Thank you.
My parents are calling me back.
I have a question relating to the anticoagulation lecture.
Thank you. It's
You brought up that 2 of the 10A inhibitors have, you estimated a 12-hour half-life. A lot of studies say it's actually 8.5 hours. But they're both, you would think, GIP drugs. And you have apixaban and rivaroxaban. Rivaroxaban came in at 20 milligrams once a day, so it's 4 times therapeutic, and then drifts down. It came out non-inferior, as opposed to the apixaban that came out superior. So one of the questions is the 20 milligrams versus 5 milligrams because it's a difference in potency, or is it because their study was 80, 60, 40, or 20, take it or leave it?
Rohit's not here, right? He's not. Oh, yes, he does.
I missed your question. You're saying that 20 milligrams of rivaroxaban versus twice a day. Yeah. Yes. Yes. So, I showed you the PK pharmacokinetic data for that. Essentially, the PK data is similar. The half-lives are on average similar, 12 hours, correct, and with a mean of 12. And only thing is they mark them doing studies once a day versus twice a day. So that is all fundamental difference of the study. So if you look at twice a day preparations, and if you leave out one dose, we still would have covered the other two. But they just did their phase 3 studies twice a day. No, it's never been shown. So it's only a pure matter of doing phase 3 studies with rivaroxaban once a day versus the apixaban twice a day. Correct. Correct.
My question is to Saibul Kaur. Saibul, I was excited to hear about Michael Cliff. I don't think the time allowed you the luxury of talking about Michael Cliff. And also, I wanted to hear a few words about parachute trial. Would you be kind enough to share those thoughts?
Yeah, sorry. One of the things I first wanted about the mitral, the way the approval is now in the US. So in the US, it's been approved for high-risk patients with a primary MR. The FDA has not approved it for functional. And as Raj said, the larger population is functional. So that's the difficult trial that we are doing now, is taking patients who have functional MR and who are not surgical candidates. They can be not indicated, and then randomizing to best medical therapy versus medical therapy plus I personally think that this trial is going to be positive, and that will become just two floodgates. For mitral for primary MR, as Jim Mendes is one of the most safest procedures that I have seen. We've done 262 cases in Cedars. We have yet to lose a patient in the hospital. We can't claim that for angioplasty, we can't claim that for even TAVR. So I think the beauty of the procedure is its safety. There's a question that Jim brought up, a very interesting question. Now, mitral valve replacement is going to come up, right? And sooner or later it's going to become really feasible. And the MR reduction will be dramatic with mitral valve replacement. The question is whether maintaining the mitral valve apparatus is more important with some MR versus changing the valve. And I showed a slide that the best bioprosthetic valve in a patient is his own valve. So my theory is that in patients whose valves are repairable, you should do a percutaneous repair procedure. And those patients which are not repairable, those should be replaced. You should still preserve the apparatus. This is very different from an aortic valve, because the aortic valve is a tri-leaflet valve, the mitral valve is an apparatus. You maintain the apparatus. And this is particularly important when you're doing LV dysfunction, when you're looking at cords. The other study that you asked me about the parachute.
Basically, going back to the previous, what you're saying is there is no need to reinvent the wheel. You already invented the wheel in surgery.
That's
so
correct.
don't do it all over again.
That's right. Why would we have a history repeat itself? So that's my personal bias towards it. We've seen that with the patients of EF of 20%. There's actually a patient of Dr. Sandhu, which I would have loved to show. He was a patient who was stripped. What's his name?
Do you have the slides?
No, I don't have the slide of this patient, but it's an amazing case. A patient with a EF of 20% was transferred to Cedars.
Hey guys, pay attention to this one. This is Dr. Saibul Kaur is doing a study on, it's called parachute. And it's
parachute. Yes, I'm going to. I was just going to tell you about the mitral case, because how it's important. The patient was a EF of 20% and came to Cedars for a consideration of a transplant. Because of social reasons, the reason he was not a transplant candidate. He was going to be sent home back to Bakersfield on a dopamine and a milrinone drip because they couldn't take it off. He had a mitral clip procedure. He came off the drips within 2 days, and I think he's still alive here. If he did not, so maintain the contraction of the ventricles.
See, that's a contradiction in terms, actually, because we didn't talk all in that when you have severe mitral regurgitation, you take the regurgitation away, you're going to lose the contractility, right? So basically, what's amazing about what you're doing is you are not only not losing the contraction, you're adding to the contraction. So how do you explain that paradox?
So you brought up a very good question. This is called the pop-up valve phenomenon. That people know that if you have severe MR, the ventricle has two outlets, the aortic and the mitral. The surgeons are here and will tell you that. And when you replace or repair the valve surgically, they often crash and do very badly post-operatively, right? But that's due to cardioplegia. We have found in mitral procedure on the opposite. The patients tolerate the procedures very well. And the reasons for that is that when you reduce the MR and maintain the architecture, you have an increase in forward flow, right? Because you're regurgitating forward. When you have an increase in forward flow, the pressure initially goes up and then goes down, and the systemic vascular resistance drops. So your actual afterload reduces. So you tolerate the procedure very well. So it's a very different from the pop-up valve. They actually tolerate the procedures extremely well, even with very low ejection fraction.
So would you say that if the valvular structure is intact, irrespective of the etiology of mitral regurgitation, and when we have severe valvular dysfunction and class 3 or 4 CHF, mitral clip is
if it's clippable.
That's what I mean. If it's
The
clippable,
pathology is clippable.
right? So then it's a default class is.
Yeah, and I think the fair deal is that there should be officially trials comparing clip versus replacement at a certain point of time. It's for functional MR. For primary MR, if you have a flared P2, you should repair it. I mean, that's the question. You shouldn't replace it. Just one more thing on parachute. Or do you want to comment?
Just one comment on this. The patients who are inotrope dependent, severe LV dysfunction, a lot of them do have functional MR. Most of the time it's because they're volume overloaded. So the critical thing to do is get them volume optimized and then evaluate the valve. And when we've done that and when they've had persistent severe mitral regurgitation, that's when we consider clipping their valve. And we've done 5 cases to date, and all of them have been able to come off inotropes and walk home. So this is early data. It's a proof of concept more than anything. And we only have short-term follow-up, but it's very promising.
That's what it is, very promising.
I think Jake's correct that if you for evaluation of functional MR, yes, you're right. You have to be euvolemic when you assess MR. Because when you're overloaded, you can have very severe functional. That's the correct thing. Functional MR is only when you're euvolemic, and if it still persists, then repairing the valve in some fashion is important. Now, the other thing I would like to talk about is the parachute study. I'm sorry I couldn't show slides, but what is there that if you take patients with ischemic cardiomyopathy, with ejection fractions of 35% or less, and if you have an akinetic area or hypokinetic area, we have a procedure where we actually can deploy a cortex cone, which actually excludes the apex of the heart. And by doing so, what it does is it removes the contractile segment, hypokinetic segment. It improves the efficiency, decreases the wall stress, and improves the diastolic function. So it's a very nice study, and we actually have done 4 patients, 3 randomized to device, 1 to medical therapy, and it's a 1-to-1 randomization. So if you get a patient of EF of less than 35, NYHA class 3, and you don't think there's going to be a transplant candidate or even a bridge to it, you can consider this procedure with optimal medical therapy. It's optimal medical therapy plus parachute versus just optimal.
So it's basically it's a Batista operation without the stress, right?
Without surgery, without cutting the chest. And yes, the endpoints are primarily repeat hospitalization for congestive heart failure, quality of life, NYHA class and 6-minute walks, and the secondary endpoints is functional.
This parachute really reminds me of the Stitch trial, and it's so using that as a caveat that had cavities in addition to transection in repair of mitral valve, and the outcomes were adversarial. The Stitch trial was a negative study, except that functionally there was improvement in functional status for 6 months. So, yes, so you may not see hard outcomes reduction. You may see functional improvement, which is a good thing that you're using functional outcomes as your primary endpoint.
The PI and Phil knows who to go for it. mortality or not. And especially in smaller studies of 300 patients each, it's difficult to actually show mortality, and we don't intend to do that.
Like the stitch trial.
But it's different. In this, you're really not operating on the patient. So that's why the morbidity associated procedure is so less that it actually may preserve muscle. Because you're not touching the muscle at all.
You're making the point, Rich, about repair versus replacement. So before, surgical repair was the only option at one time versus, the valve replacement. So all the data that we have, that when you put in a valve, you increase the afterload and the succumb perioperatively, is very old data. Even that did not address functional repair as the outcome. So if you maintain the geometry and the architecture and some mitral, even the surgical repair data that they recovered, they did not succumb, the EF didn't drop at that time. So which is parallel to what you're doing in the UK.
It also is that nowadays, even replacement, the surgeons don't remove the subvalvular apparatus. They try to replace the valve with preservation of subvalvular apparatus. And when you do transcatheter valve replacement, that's going to happen, right? It's going to be a valve replacement with preservation with the apparatus. So, my question.
I have one other comment about the mitral clip, and that is, I was just last week in Saudi Arabia, and we had a discussion of mitral clip where they're not using it in a research vein, but they're using it clinically. And the use is about 3 to 1 for functional mitral regurg as opposed to primary MR. And that is, I believe, that's completely different. It was 3 to 1 in the Everest trial for primary MR versus functional. But the place where this is going to find its actual clinical application after it gets out of trials is in functional MR with low ejection fraction.
Well, the truth is that in the Everest trial, the randomized study was a low-risk patient, so they were surgical patients. But if you look at the high-risk registry, the high-risk registry, 60% were functional MR, 40% were MR. So, and you're right, if you look at the population, there's a larger group of functional MR who surgeons don't want to operate on, right? Surgeons are happy to take a 45-year-old with a flared P2. They won't give you that patient. But when they see a 75-year-old with a previous CABG and EF of 30%, they say, give it to you. And these are people who don't have a good alternative. So that's why this population is larger. And that's why it is very important.
Yes. These paper on ring and run, weren't all those functional MR with a lot of patients who were for transplants, and he managed to manage them without.
Right. So talking about Steve Bowling. Steve Bowling was the man who did the biggest proponent for repair using the undersized ring. A couple of things about those data. What he did show is that when you repair the patient with functional MR, first of all, they tolerated the procedure. That was a good thing. Second is they had improvement of symptoms. That was a very good thing. What he didn't show is a mortality benefit. And that was an issue. And the third thing that he showed was a high recurrence rate. 30% recurred after repair. The difference between ring annuloplasty, which you standard do, versus a clip is a ring annuloplasty is at the level of the annulus. The clip is at the level of the leaflet tip. So it's a slightly different repair technology, and we don't know whether the recurrence will be the same or not. But we don't think necessarily that we will show survival benefit because they are dying of their ventricular disease. What we do want to do is at least improve the quality of life. So I actually wrote an editorial on this that said it's more important to add life to years, not necessarily years to life. Yes. Yes, of course. If the diameter of the annulus is very large and the leaflets don't quite together, then it's impossible to do the procedure. So we obviously have a limitation of how the annulus is done.
I just want to say I agree with what you're saying, Saibo. The data, the surgical data shows that with functional MR, because of the high recurrence rates with repair and the lack of mortality benefit, and actually the patients that undergo mitral valve replacement do better than the mitral valve repair with functional MR. And so I suspect that perhaps with the mitral clip, I think that the results may be similar to what we've seen with annuloplasty, long term.
So what his question is that most of the repair data shows a 30% recurrence rate, right? So that's one of the reasons why people are saying, you might as well repair it, you might as well just replace the valve. What we have found is that a lot of patients are left with 2+ MR at the end of the procedure, but they don't get worse over time. They stay the same. It's different from a ring annuloplasty where they go to trace at the end of the procedure, but when they come at 6 months, they're moderate to severe. So there's a difference. It's that we're left with some residual MR, but we don't recur, versus the ring annuloplasty where they do well initially, but then recur. So it's slightly different. It's not exactly the same as.
Okay, so while Dr. Carr is on the docket, I want to put a little more heat on him, mostly towards stroke prevention. So Saibal, I'm just a humble electrophysiologist.
That doesn't die.
So talk to me about the lariat. Okay, so how can one suture in various parts of the body work the same way in the heart? How are you willing, as Professor Saibal Carr, to accept the lariat without a trial?
As you know, I'm biased towards the Watchman device, so I don't agree with the lariat data, and I agree with you that it's not clean as the Watchman data. And what lariat people are doing is that we are using the Watchman data to support the closure of the appendage. Right? That's true. And I agree with you, Sumit, about that. That's absolutely fact. That the data, if you look purely from a data standpoint, it's the Watchman has the data, the lariat don't have the data. Now, saying that, there's some things about the lariat that are interesting. The first thing is that there's no device left inside the heart. It's a ligature of the atrial appendage and completely sealed. And so potentially, you won't have a thrombogenic surface inside the heart. And this can potentially have long-term potential. I'm saying there's no theory. The second thing is that you colleagues have been talking about isolation of the atrial appendage as a mechanism of treatment of atrial fibrillation. I don't know the mechanism, and Mike, you can answer that question. But I don't know the theory, but this is a theory that you guys are talking about. Having said that, I still support, of course, the spot.
Perforation, slow, moving organ. The second when you have people with refractory heart failure, what this really works very well is the inclusion of a loop bladder in combination with the you can probably get anybody out of left ventricular failure, especially people from the cardiology shock after big elevation MI. Put them on the balloon pump and start them on I never use inotropes. Kind of correlation for clog or dying ventricle, clog or dying horse. But start a loop bladder paradoxically go back and you have a central arterial catheter. Waveform. DPDT rise is very huge. Cytokine storm as opposed to a cardiogenic shock. Situation more so right off
Yeah, so you make a good point. The acute the acute cardiogenic shock process, particularly post-MI, is a different animal because you already have reflex neuroendocrine activation. And inotropes are just going to aggravate that. And to support that ventricle, you want to unload the ventricle. So a balloon pump may be enough, but often you need something more aggressive, an Impella or even an ECMO or something of that nature. And for those patients, if you're able to maintain enough renal perfusion, you should be able to diurese them. Okay, and I would certainly recommend the use of loop diuretics in that situation, and I would not recommend the use of ultrafiltration in that acute situation, because that's the patient that's at risk of cardiorenal syndrome, and that's the patient that's going to end up with renal failure if you're very aggressive with ultrafiltration. So that is exactly the patient that you want to avoid.
That same note, patient one of the reasons are cardiac transplant are a little lower. Some of our patients don't have the intelligence, I should say intelligence for the social setup to follow the post-transplant protocol. But that how it works in that clinic and on the post. You give them a high dose that everything is over. Make the urine interaction go into the breathing. Just MR improves. Actually, the patients have a use oil for instead of bleeding with spironolactone and MR improves. The functional three patients have been recalled. Severe cardiomyopathy and stage repeated hospitalization. Safety and transplant for 8 to 10 years. One guy got rejected by 3 transplant centers. Cedars first went to Stanford and came off to another center. They didn't feel that he was going to be the right candidate. That combination and giving microtreatment along with this combination for an extended period of 10 years. Also, I just thought I would share you your thoughts. I don't know whether you like this combination of two diuretics.
Jake told it correctly that we only assess the severity of MR after the patient's eubulemic, right? And in the COAP study, which is a very well-designed study, you have to be eubulemic at the time of the MR assessment. So let's say a patient comes with functional MR, you send the patient, and I send it to Jake, and then Jake says he's not optimally managed. That echo doesn't count. He has to be optimally managed, and when he's dry, that's when we do the echo. And if he still has severe functional MR, then he gets randomized. See, so we do think that it's only for those reasons.
Question is from Dr. Shah, and he was regarding the
I think that more and more people are doing that. And I just want to mention that with regards to the Lariat device, we've done, I think that people have shown that when you just do a purse-string suture at the base of the left atrial appendage, there's a high rate of incomplete exclusion of the appendage, which is how this device works. And so the best way to do it is either just to, amputate the appendage in order to sew it, or, with these thoracoscopic mace procedures that Juanizad is doing, with the AtriCure with the clip, that's just a very high rate of complete ligation in both class or recanalization.
Jay, this question is more clinically oriented. Talking about people who are late 80s, early 90s, mid 90s, have diastolic CHF, have baseline CKD and AFib, obviously, and multitude of other risks. And those are the people we're struggling to keep out of the hospital. It's always a challenge of balancing the metalazone and Lasix and AKI over CKD and stuff like that. It's like weighing gold. You can almost never get the needle point in the middle. That's the struggle we have. It's not the destination therapy and stuff like that. It's the people that don't see it.
So the group of patients with diastolic heart failure, what's called heart failure with preserved ejection fraction, are really the most challenging cohort, and it's a significant cohort because we have yet to demonstrate a single pharmacologic therapy that has any meaningful impact on long-term survival in these patients. The spironolactone was recently shown at best to reduce hospitalizations, but that's it. Many of these patients are very challenging simply because they're at higher risk of developing atrial fibrillation, and once they get atrial fibrillation, their heart failure gets much worse. And maintaining a euvolemic state is very challenging. Now, there are a number of patients with diastolic heart failure who have amyloid. And there are some therapies that are now emerging for amyloid, and we are actually about to participate in a couple of clinical trials using drugs which interfere with amyloid deposition. One is a drug called tafamidis, which stabilizes transthyretin protein. And the idea is that with this drug, we decrease further deposition of amyloid into the myocardium. This is a drug already approved in Europe for prevention of neuropathy in patients with transthyretin amyloid. Another interesting drug that we'll be considering down the line is a novel type of therapy, which is called an RNA interference molecule. So you're basically infusing interfering RNA molecules that prevent synthesis of the amyloid protein. And this will be for African American patients with a certain type of mutation, which is very common in causing amyloidosis for them. But this is all at a very early stage, and in the meantime, therapies for diastolic heart failure remain very frustrating. It's a disease of the elderly, and unfortunately, really hard to deal with.
The second study and a lot of right heart failure or they get diastolic CHF. I think if you cut the $30 billion expense of heart failure, what test, what brand has PR is BNP. And there is a lot of appropriate hospitalization happens because the BNP is high and the PR doctor has a solid proof that can argue. If you have, women actually have some related
So you make a very good point. The Breathing Not Properly study, which is the original study looking at the utility of DNP in the diagnosis of heart failure, was only designed for patients presenting in the emergency room with shortness of breath of undetermined etiology. Okay? So that's the only time that a BNP is of any help. All the time I see patients in the hospital with the house doctor drawing daily BNP on patients. What is the point? There's only two times when a BNP should be drawn. One is when a patient's in the emergency room and you truly don't know what's going on in terms of their shortness of breath. And that's very rare because with a good clinical exam and a chest x-ray, you should be able to make a diagnosis of congestive heart failure rather than relying on a test. The second one is if you have a heart failure patient and you want to determine his prognosis, to do it at the point of discharge, because that will tell you what his prognosis is.
Okay. No, Sunil, that's enough. That's enough. Guys, the cross-examination, and Sumit has one last question, and that's the end of it.
Actually, this is actually more like some philosophy from Professor Forrester. So since the red is rather drinkable, can I ask you a philosophical question, Jim? So I really enjoyed your talk. And in some ways, I'm envious of your experience. You know, but hopefully, people in this room will have similar experiences, if not yours, right? I love the spice that you added in. I'm waiting for your book, and of course, I'll have it signed. So, but what I want to ask you is that there are some young people in this room, but mostly there are people who have children who want to be physicians. What advice do you have for the youngster who wants to be a cardiologist in view of your experience and your very practical knowledge of today's world?
Well, back in the 60s, there was a famous professor at Columbia who said to each of his students, follow your passion. Find your passion and follow your passion. And I think that is key. Your children, if they want to go into medicine these days, must find a passion in it, or perhaps they should not go in that direction. This is a more difficult time nowadays. But if you can find the passion, which I hear in the questions that each of you have asked, and in your answers, we got the passion, don't we? And if your kids can find that, then they ought to go there too. I might just say one thing, since this is the end of it. It has really been fun here to come up to Cedars-Sinai North, where we have sent our best trainees over the years. And you say, how do I know that they're our best trainees? Well, when I was chief of cardiology, I don't know for sure this is still the case, but when I was chief, we had 600 applicants for 3 positions in our fellowship. And these are the guys, and these guys are the ones who won those invitations to come and be our fellows. Now, for us, and some of them you met today, I was fortunate enough to be a mentor to some of you. So was Raj and Saibal, Frank Litvak, and Neil Eigler were certainly important in some of your careers. Bob Siegel, P.K. Shah. Being a mentor is a wonderful experience. At my own mentor, the obituary of my own mentor, Jeremy Swan, I said that a teacher never knows where his influence ends. It affects eternity. And that is going to turn out to be true for us mentors as well, because of what you, Bridge, and your colleagues have established here in Bakersfield. You actually have created the leading cardiology program in all of Central California, and you started with virtually nothing when you began. So it is. I hope that this will continue. This conference that you have established, this first one, and it will be a joy for all of us who are at Cedars to come up and join you, because among all of this is the friendship that has been created and will continue through events such as this. So I personally want to thank you, but I know I'm thanking you for all of us that you have invited up to be with you today.
Gentlemen, it's Thanksgiving. You're officially pardoned, so you can come over.